So good evening, everyone. Thank you for making time for today's Fireside chat. This is going to be a 159th webinar series, and we are quite excited to again continue with our webinar series on kidney transplantation. My name is Dr. Yuri Okech. I'll be the moderator for this session, and today we have our guest speaker, who's Dr. Brian Alvarez. And we're really excited to have him on board. And he's going to take us through a topic on deceased donor transplants, looking at brain dead versus donation after cardiac death donors. So just a little bit about Dr. Brian. He works at the DTI Foundation, and he heads the international cooperation programs to enact donation and transplantation networks in the world, while also participating in training and innovation activities. He is a critical care specialist and organ donation coordinator from Argentina. He has an international master's degree in organ, tissue, cell donation and transplantation from the University of Barcelona, and has been elected as a European Counselor for the International Society for Organ Donation and Procurement. So we are looking forward to a very enlightening discussion from Dr. Brian. So over to you, Dr. Brian. The floor is yours.
Thank you, Dr. Shuri. Thank you so much. Thank you all the organization for this opportunity to be here and share my experience with you. So as Dr. Shuri just mentioned, the title or the objective of my presentation today will be to talk about deceased donor transplants. I will talk about both techniques now used. Is what's called donation after brain death. That's what we call DVD, and what is called donation after circulatory death. That's what we call DCD. So we will go a little around the system, what we need to implement a deceased donor transplant program, and a summary of both different techniques. So the first thing that we need to go through is why transplant our patients? No, which is the need to implement a deceased donor program and initiate a transplant program? So first thing to mention is that for some organs, transplantation can be an option, like for kidneys, where we can have our patients on dialysis or transplant them. And for some organs, transplantation can be the only life-saving option, like for a heart, for a lung, for a liver, where we don't have a alternative treatment for that. But even in the kidney, where we can use dialysis, we can see that transplantation offers us a better survival compared to dialysis, being the survival after 5 years of dialysis around 50%, whereas on transplantation, we're talking about 92–95% of survival after 5 years of being transplanted. But we can also offer a better quality of life, instead of the patient being on dialysis, going 3 times per week to connect to a machine. Now this person can be free of this treatment, and can be, sometimes dialysis can be quite disabled, where a patient with dialysis transplant can have a totally normal life. And there's a special benefit for younger patients, where their neurological development can be affected by the chronic kidney disease, and this can be avoided. But still, even though if we implement a successful transplant program, we will always have patients on dialysis and patients on transplant. The ideal situation, that is what's happening now for us in Europe, as you can see in the video figures, is that we are having each time more patients being transplanted, but still we will always have patients on dialysis. Now almost half of the patients are being transplanted, and half of the patients are still continuing dialysis. And most of our patients requiring dialysis are the older patients, where younger patients are getting access to transplants and are being transplanted. But it also is not only a better quality of life, survival, but it's also good for the country, because if we opt for transplant, we are helping solve inequities, and we are saving money. No? We see that in low-income countries, the majority of the patients die or stop their treatment within 3 months. And this is because dialysis for countries is costly, and for low-income countries is even more costly. But if we opt for transplant, we can recover each after 1 year, between 1 and 2 years post-transplant, the cost of this transplant is lower than keeping that patient on dialysis. So for the country in general, the country is saving money after between 1 and 2 years, because it depends on the volume of transplant we have. The more donors we have, the less costly it is. But between 1 and 2 years post-transplant, it is cheaper transplant than the dialysis. So it's good for the patients and it's good for the country to implement these kind of programs. But even though we know that, we can see that around the world, only 10% of the global needs for transplantation are covered. This means that from all patients on dialysis around the world, only 10% will get a transplant, and 90% of the patients will continue waiting or die on the waiting list. And this problem is the gap that we talk about, is self-sufficiency, is a country's capacity to cover all the country's need for transplantation with their own donors from that country. And this self-sufficiency cannot be achieved only with living donation. We know that we can have living donors or deceased donors. In the case of a living donor, we can donate the kidney or the liver. So for heart, for lung, for pancreas, we will rely on the deceased donation. But even for the kidney and the liver, only 30% of the total number of transplants in the world come from living donors, and 20 of the livers come from living donors. This means that even if we can implement a good and successful living transplant program, we will never achieve this self-sufficiency. And this is why we always need to implement a deceased donation program to cover that needs and to make sure that everyone needing a transplant can get access to transplantation. And in deceased donation, we have two different types of donors. As we mentioned before, we can have what we call DVD donors. These are donors after brain death, and what we call DCD donors. These are donors after circulatory death. This means that brain death is the total loss and irreversible loss of all the brain functions, and for us, brain death is equal to death. So in the past, we were talking about brain death and cardiac death as different things, but nowadays we understand that death is only one, and it's the loss of the brain functions. And we can reach that death either by neurological criteria or by circulatory criteria. So understanding death as only one phenomenon, we can reach that by a circulatory way or by neurological criteria. Okay, so this is why this is divided this way. It's the same death, different ways of reaching the diagnosis. Okay, in the case of donors after brain death, I will explain now how is the process, while it's quite different for donors after circulatory death. And in the world, this is the number of transplants that are performed all around the world in 2022. As we mentioned before, only less than 10% of the global needs are covered. And the main source of transplants in the world is deceased donation. And from these deceased donors, 22% of them come from donors after circulatory death, where almost 80% of the donors are coming from donation after brain death. Okay? And this makes quite sense, because most of the times countries are starting with living donation, then are implementing donation after brain death, and finally start implementing donation after circulatory death. So how is the process? Usually, the profile of the patient that can become a donor is a patient is admitted to the hospital with a devastating brain injury. This means a brain trauma, a stroke, brain bleeding, an anoxia, an infection, a tumor that generates intracranial hypertension that makes the patient in coma due to this lesion. That's why it is devastating. And there, in that moment, is when we have to detect this case and start following up to give the opportunity of organ donation in the process. This case, admitted to the hospital, can recover and be discharged, but if not, this patient may die And if they die, they might do it by neurological criteria, by losing all the brainstem functions. And this is when we certify death. And when we certify death by neurological criteria, by brain death, the next step for this patient is to be transferred to the morgue and to be declared death. In countries where we have disease donation, instead of transferring the patient to the morgue, we can offer the opportunity of organ donation before disconnecting the ventilator. And this is what we call donation after, where the other pathway, the donation after circulatory death, these are patients, these same patients admitted to the hospital, but that they don't reach the point of brain death. They still have some neurological response, either some brainstem or cough or a minimum respiratory effort. And these patients do not progress to the point of brain death, but we understand that for this patient, there is no good quality of life after the treatment. This patient will not recover, or sometimes that the treatment is not what the patient wanted for himself. And this is where the end of life care discussion starts. And we have two ways of making this decision on the end of life. We can either decide to DNR the patient, and we decide not to escalate the treatment or not to do CPR in case of an arrest, or what is the same is the option to withdraw the life support treatment. If we understand that this treatment is futile, we can withdraw the treatment, remove the ventilator, let the patient die in comfort, sedated, and certify death. And in this, if we opt for this option of the withdrawal of life support treatment, then is when the patient may die in a controlled environment where we know the exact time, the withdrawal and the death, and where, since the patient is so severely ill, the expectancy of the patient to continue and to survive longer than 30 minutes is low. So in these cases, it's what we call donation after circulatory death in a controlled environment. Okay, it's this patient that we finally decide to withdraw the life support treatment because it is for the best interest of the patient. And when we make this decision, we can open the opportunity of organ donation as an option in these cases. Okay, this is the controlled DCD. So starting for the donation after a neurological certification of death or the donation after brain death, the process of the DBD starts with the detection of a possible donor. This is a patient that's admitted to the hospital, as we say again, with a devastating brain injury, and that this patient we know that has a bad prognosis and has a Glasgow Coma score below 5, and we have to detect this case and follow this case. We don't change the treatment, but we know that we want to follow this case to be able to diagnose the brain death early and on time. So the first step for us is detecting the case and screening if there's any absolute contraindication for donation in the first days of admission. Now, if this patient is not recovering and finally progress to the stage of brain death, and we suspect the patient could be brain death, this is when this patient can become a potential donor. And in this case, what we're going to do is we're going to diagnose the brain death, doing all the testing, doing all the exams required by law to complete this diagnosis, and we will start our management to treat all the complications related to the brain death process. Finally, once we completed the brain death diagnosis and we certify the death, the patient becomes what we call an eligible donor. And this eligible donor is when we will talk to the family, explain to them the brain death diagnosis, and offer to them the opportunity of becoming an organ donor. Finally, after we get the family consent, we will organize the retrieval to retrieve the organs and the allocation of that organs through a national system where we should have a waiting list to prioritize who is the person that should get this organ, and that way we can allocate the organ, transplant, and this becomes an actual donor. As we mentioned before, the main reasons for our patients admitted to becoming organ donors or to progress to brain death are brain trauma, cerebrovascular accidents, brain anoxia, tumors, and infections. In the past, the main source of donors in our countries were trauma, but as the profile of our patients are changing and the society is becoming more elderly, nowadays our main source is being brain anoxia and cerebrovascular accidents, and the incidence of brain trauma is decreasing. So nowadays we have more stroke, ischemic stroke, brain bleedings, aneurysms, and it's easy to elderly donors than before. But usually the paradigm of donation was a brain trauma or a brain bleeding being the main sources of donation. And for us to understand which is the potentiality of how many donors we could have in our hospital, we estimate in our hospitals that 14% of all the patients dying in our ICUs, they could be potentially donors. So if we understand that, we can understand how many patients every day could be dying in brain death in our ICUs, and we are not detecting them. We are not suspecting this brain death. This is why it's important to implement an efficient and good donor detection system in an early stage, so we can make sure that when 14% of them progress to brain death, we identify them, we diagnose the brain death on time, and we offer this opportunity of organ donation. Once we suspect this brain death, the next step is to certify the death, and certifying the brain death diagnosis is, we have to understand this is maybe the most important diagnosis in medicine, because we need to determine if a patient is dead or alive. So this diagnosis must be done by someone that is trained and certified and confident in doing this diagnosis. And this is very important to make sure that when we do this diagnosis, we cannot make any mistake. And this is why in many countries, this diagnosis is done by more than one physician, or that we may require ancillary testing to ensure the safety of this diagnosis and that we never do a mistake in this testing. And this test, when we complete this brain death diagnosis, is crucial, because when we certify the brain death, for us, this is the time of death of our patient. Okay? So for doing this brain death diagnosis and brain death testing, the first step is to make sure that there is no confounding factor. Some conditions may mimic or make us lose some neurological response, and this may confuse our brain death diagnosis, like ensuring a normal blood pressure, a normal temperature, a normal glycemia, and that there is no effect of any sedatives. After that, we're going to do the full physical exam, testing every brainstem, reflex, and testing the breathing efforts. A brain death patient is a patient who has CCS, no neurologic response. We test every brainstem reflex. They are all absent. We disconnect from the ventilator. We wait 10 minutes. We take blood gases, and we do what is called apnea test. So we demonstrate that the patient is in apnea, there is no breathing effort, that all the brainstem has been lost. And then is when clinically we can diagnose the brain death. Sometimes, to complement this clinical diagnosis, or to guarantee there is no flow or no function in the cortex, we may need to use flow testing, like a CT angio or an angiography, or a transcranial Doppler to measure there is no blood flow in the brain, or electrical test, like an electroencephalogram, to demonstrate there is no electrical activity. But the brain death diagnosis is a clinical diagnosis. We clinically diagnose the brain death, and we can complement it with an ancillary test. When brain death starts, and this is why when I talk about donor management, I talk about every stage before completing the brain death diagnosis, because when brain death starts, usually starts with a catecholaminergic storm, with tachycardia, hypertension, sometimes fever, but after that storm, all the organs start failing, and these physiologic changes in brain death mean cardiovascular changes, neuroendocrine changes. This means suprarrenal insufficiency, diabetes insipidus, all the hormones generated by the hypophysis and hypothalamus will be lost, and this will be the complications related to the brain death. Metabolic complications, respiratory complications sometimes may generate a respiratory stress syndrome, and coagulation, which may generate intravascular coagulation syndrome. And all these complications may lead to organ dysfunction. And if we don't treat them on time and in an early stage, this will lead either to the organs not to be suitable for transplantation or our donor to arrest before we can complete the brain death diagnosis and talk with the families about the option of organ donation. That's why a good donor management needs to start early. But we are not concerned about initiating our donor management before completing the brain death diagnosis, because we understand that a good donor management is a good ICU care. So if we are thinking of this patient as a patient, if the patient is alive, we will be giving a good treatment to our live patients. And again, there are lots of evidence showing that a good donor management is a good ICU care. And if we don't do a good management and an early management, we will lose our donors and we will lose the opportunity to transplant more organs from these donors. Once we completed the brain death diagnosis and we are doing a good management and stabilizing our donors, the next step is to talk to this family and not only talk about donation, but mainly explain to them the concept of death. And this is the main challenge for families to understand and accept this concept of brain death. Usually, the problem behind the family refusal for brain death diagnosis is not related to the concept of organ donation. Sorry, the refusal for family for organ donation is not related to the concept of organ donation. It is usually related to the concept of accepting the brain death. So those families who don't accept the concept of brain death, most probably they will disagree to the option of donation. So it is only when we have confirmed their understanding and acceptance that we talk to them and explain to them that the patient has died. Only when they have accepted this diagnosis, we will talk to them about organ donation, about the possibility to donate the organs, and then the families most probably will accept this option. And then we talk about a different source of organs. No? We talk about this donation after circulatory death. And these DCD donors is a quite new source of donors. I started a long time ago in Spain, but they have been more diffused in the last 10 years all around the world. And there are different categories. Category 1 are patients that are found in the street already dead with clinical signs of death, and they cannot be donors. Category 2 are patients that have a out of hospital or in hospital unexpected cardiac arrest, and that we try to resuscitate these patients, but after an unsuccessful resuscitation, we consider the option of donation. Category 3 are patients that we decide to withdraw the life-sustaining treatment because it is for the best interest of the patient, and when we stop the treatment, the patient arrests, and since they arrest in a controlled environment, this is what we call controlled DCD. And there are two options, less frequent, that's what we call category 4. These are patients that are in brain death and have a sudden cardiac arrest, and we decide to go straight to the OR to retrieve the organs to avoid losing the donor. And category 5 is new here in Spain, is what we call the donation after euthanasia, patients that decide to opt for the euthanasia because of different kind of conditions, and we have to offer this possibility of organ donation to these patients, and when they accept, we do this in a controlled environment. So I will go into more details about the uncontrolled and controlled, being these two are the main sources of DCD donors. As I said before, the main source of donors is 80% of the donors in the world come from DBD, donation after brain death, and 20% of the rest come from DCD. But from this DCD, the main source are these controlled, these patients on the withdrawal of life support, and a lower percentage of them are coming from uncontrolled DCD. So how does this uncontrolled DCD look like? We talk that this is a patient that in the street has a cardiac arrest, that someone present this cardiac arrest, that we initiate CPR, within the first 15 minutes of the arrest. And after the CPR, after 40 minutes or the time that they need, they decide to stop the CPR because the patient is not recovering, and they transfer this patient to the hospital. Once the patient arrives to the hospital with a continuous CPR, we stop the CPR, we stop the ventilation, we wait 5 minutes, depending on each country. In Spain is 5 minutes, in Italy is 20 minutes, in UK is 10 minutes. Depending on each country, we have different times of what we call no-touch period. So it's a period that we stop and see that the patient doesn't have an auto-resuscitation. And after this no-touch period, if the patient doesn't have an auto-resuscitation, the line is still flat and there is no pulse, we can determine the death. So this is when we determine the death, and after that moment, this patient stops being a patient and is now a cadaver. And since this is now a cadaver, we can consider this the opportunity of organ donation. And this is when we initiate our organ preservation. We connect this donor to an ECMO device, but this ECMO device has a balloon in the aorta that only makes the flow inside, that only has a balloon here in the aorta, guarantees that the flow is only inside the abdomen. So this donor will have all signs of mortis in the lower limbs, in the inferior limbs, but the abdomen, we will see that the abdomen is adequately perfused and the kidneys are perfused. So then we were able to talk to the family, ask for a consent, and if they accept, we go for the organ retrieval. Again, the prevalence of this kind of donors is lower, but this is what we call uncontrolled DCD. Of course, these are patients 2 hours or up to 2 hours and a half of ischemia time. So of course, usually these kidneys have a delayed graft failure, and it's a little more difficult to manage them. But the 5-year mortality and graft function of these grafts are the same as a donor after brain death. So it's a good source of kidneys for organ donation. Then we have this other group, no? This group that we call the DCD3 or the controlled DCD. We mentioned that these were patients in our ICUs with this massive brain injury or any kind of disease that we consider that the treatment is now futile, or that the patient decided to refuse for this kind of treatments previously. And then we consider that continuing the treatment in this patient, since this futile or the patient refused to this treatment, it becomes unethical. So we cannot continue with this management. And we consider in this case it's a good clinical practice to stop our efforts and let the patient die with dignity. No? Instead of, there are different kinds of withdrawing the support. We can either DNR the patient, we can not escalate the treatment, but actually withdrawing the treatment is what in fact will become the most ethical practice, because we're guaranteeing that we are not prolonging the process of death, and that we are ensuring that our patient is not suffering in this process. As it says here, no? Not doing the withdrawal of life support does not prolong life, but only prolongs the process of death when we know that the treatment is futile. So in these cases, we decide the withdrawal of life support, so we can talk to the families, offer this opportunity of organ donation, and if accepted, initiate this controlled DCD procedure. And how does this procedure look like? What is the patient that we decided to withdraw the life support? So after we withdraw, we remove the tube, we give sedatives to ensure that the patient is not suffering, we stop any vasopressor, and the patient will progressively start dropping. The blood pressure will start dropping, the oxygenation will start dropping, until this point where we consider the ischemia starts, and this is where we observe until the cardiac arrest happens. If this cardiac arrest happens in less than 30 or 60 minutes, we can consider the kidney of the patient a possible candidate for kidney or liver donation. So after the circulatory arrest happens, we wait this no-touch period. Again, as I said before, it can be 5 minutes, 10 minutes, 20 minutes. depending on each country's legislation, the usual is 5 minutes. So after these 5 minutes, we stop, we see there's no auto-resuscitation, and we determine the death. And when we determine the death is when we can initiate our organ preservation. So here is when we either, again, start ECMO inside the abdomen, or we can do an ECMO thoraco-abdominal to perfuse the heart, the lungs, the kidney, the liver, to retrieve every organ. Or in some countries, we can do the super rapid retrieval. This means if we don't have the ECMO, or we cannot expend the money on the ECMO, we can also do what's called rapid retrieval. We open the abdomen quickly, we cannulate the vessels, and we initiate the perfusion of the cold preservation solution, so we avoid the warm ischemia time. Or another technique that we used to use here in Spain is the double balloon triple lumen catheter. We insert a double balloon, which is one of them in the iliac arteries and in the bifurcation of the iliac arteries, and the other one in the aorta. And through this catheter, we fuse the preservation solutions and we drain through the veins. And this way, we already start the infusion of cold preservation solution faster, and we can preserve the kidneys for the possibility of organ donation. Of course, with these two techniques, we will only be able to retrieve kidneys from these donors, while if we use this normothermic regional perfusion with the ECMO device, we are able to retrieve heart, lung, liver, kidneys, and the outcomes of these donors are similar to a donor after brain death. So as a conclusion, we have 3 different kinds of donors. We can have living donation, we can have donation after brain death, or we can have donation after circulatory. Usually what's happening and what most countries do is they initiate with living donation because it's the low-hanging fruit, where we can arrange it and train the surgeons, we can easily initiate a program. But then we must initiate a disease donation program because it's the only way of achieving this self-sufficiency. And to do so, the easiest way of starting is through donation after brain death, because we are able to have enough time to complete the brain death diagnosis, to do all the exams, to do the allocation. So logistically, in the organization, it's easier to initiate with the DBD than with the DCD. And then once we are confident and used to the DBD process, we implement these DCD procedures. But if we want to initiate this disease donation program, we will need some components to be there with us, to be ready for the program to start. So these are the 7 main components that we need to settle. We need to have a legislation that regulates this kind of activity. We need to have a way of credentialing and regulating this activity. So usually we have a national authority that's in charge of saying who can transplant these organs and who can donate the organs. We need to settle up the finance so we can make sure that the program is sustainable. And most important, that the donor families, the deceased donor families, have no cost. So no one should pay to become a donor. And this is important to ensure in a national way. We will need the workforce to be there. And the workforce is not only the nephrologist or the transplant surgeon, but we also will need a pathologist to do the biopsies for follow-up post-transplant, and we will need a donor coordinator. So as we have, when we think about transplant, we think about the nephro, the transplant surgeon, and we need to think about the donation side. So we will need someone to actually oversee and think about organ donation. And this person is independent from the transplant team. We need to have settled interventions and procedures, as dialysis, as the biopsies. We need to have a lab available for the HLA testing so we can match donor and recipient. And we will need to have the serologists available to be done fast so we can do it on time for these disease donors, because in these donors, each hour counts. So we don't have 1 week or 10 days to do this. We usually try to set this up in 24 hours. In some countries, it may take up to 5 days, but we cannot delay this long. The medication, if we started this kind of programs, we need to ensure that access to immunosuppression is there, but it will be enough medication available for these patients to continue their treatment. We cannot stop the immunosuppression in the middle of the treatment. And we need to have protocols in place, and not protocols only for transplantation, but also national protocols and hospital protocols for guaranteeing organ donation. And usually the main problem, and actually now in the Africa region, is that we still need to have a good legal framework that facilitates us to have disease donation. But we don't need to have much things from the legal. We don't need a law to cover everything. Usually what we do, what we have here, is we have a law that covers the basics, and then we have a national authority, and we have scientific societies that will establish the protocols and the regulations on how this law can be implemented. Okay, so what we want to the law is to the law not to say no and not to interfere, and then we can update these regulations and these protocols more frequently, and this can be catching up with the last medical evidence. So for living donation, we basically need to ensure with the law the donor safety, that the person that wants to donate is doing it altruistically, is not being paid for this, that the donor will be taken care and is correctly medically evaluated before donating, that there's a certified relationship between the donor and recipient, or that we are allowing unrelated donation, that we ensure that the donor is legally competent, that there is a consent, and there is a registry on every donor we have and every recipient we have, that this needs to be monitored and followed, because the big threat with living donation is the threat of organ trafficking. This is why the legal framework needs to ensure all these steps and have a national register, follow up every case, so we can combat and avoid organ trafficking. But then for disease donation, what we need from the law is first to guarantee what we call the death donor rule. This means that we will only retrieve the organs only once the death is certified. So either by brain death or by circulatory death, but by either of those two procedures, we have certified the death, and then we can move forward with organ donation. It doesn't mean that we cannot be in contact with the patient, that we cannot talk to the physicians. This is something that we can do, but we will not treat the patient. We will not initiate the donation procedure or retrieve any organ until the brain death has been declared. That establishes the law the clear requirements for brain death declaration. And in this aspect, if you're thinking nowadays of having a national law that contemplates disease donation, it's very important that this law contemplates not only donation after brain death, but also donation after circulatory death, that understands that both concepts are synonyms, that are the same, and that tells you adequately how to certify death by circulatory criteria and how to certify death by neurological criteria. So when the time comes that you want to switch to DCD, you have your law already in place and allows you to do this practice. The law must ensure that death is not declared by the transplant teams. This means that the team that declares the death of the patient must be independent from the transplant teams. The ICU taking care of the patient is the one diagnosing the death, and then is the donation team the one taking care of the donation part. And that every time that we opt for donation, there is a consent or authorization that is registered, is taken, and is ensured. So no one should be obliged to become a donor if there is a clear refusal previous to the death. If there was a clear refusal, no one should be obliged to become a donor. Okay, so I would say these are the four things that the legal framework needs to establish clear for us to be able to initiate these kind of activities. And when we see the word, unfortunately, disease donation is not a practice spread all around the world. So mostly this is a practice that is taking care in the world leader, the main country having the higher number of disease donors is now Spain, followed by the States, and we see many activity in many European countries, some South American countries, Australia, New Zealand. But when we see the rest of the world, we see that many countries have very low or no activity. And unfortunately, if there's no donation, there is no transplantation. Again, we saw here that Spain is the number of donors per million population. This is how we rank different countries, followed by the states. And then we see all these other countries in green that they are countries that what's called the European model. So the different ways of approaching this donation, we may have different ways of organizing the activity inside the country. There's what we call the Spanish model. The Spanish model has in-hospital teams dedicated for donation. The USA model is an outro model. We have out-of-hospital organizations that when there is a donor, they are called and they go and take care of the donation. The problem is that since they are outside of the hospital, they are not in the place where the donors are. And they will have this European model that these are different ways that different countries adapted the Spanish model to their reality, but always having these in-hospital teams dedicated for organ donation. As we said before, we started with, these are the number of donors in my region here in Catalonia. We started, as in Spain and most countries, with donation after brain death, but donation after brain death gradually started dropping since brain trauma is decreasing. And then we initiated donation after circulatory death. And nowadays in Catalonia, we have divided by three different segments. Most of our donors are coming from donors after circulatory death. Then we have living donation and donors after circulatory death. So it's basically divided in equal parts. But again, we start and then we initiated our DCD program. So it's an important message. We need to understand that organ donation is a different practice from transplantation. And since it's a different practice, different teams should take care of this. So we have the transplant teams that's taking care of the transplant side. So if we want to have donors, we need to have the organ donation team taking care of the donation side. And this is an independent team, which in our reality is taken care by the ICUs, that's where the donors are. And in the country, we need to have this national authority is the one mediating between these different stakeholders and the one guaranteeing that the practice is done adequately, transparently, and in ethical ways. And it's the one having taken care of the national waiting list, allocating the organs, training, providing with regulations, and all these tasks. This is a summary of what we said before. In the two different models, see here is that in the United States, we have these OPOs outside the hospital that they provide the service of organ donation. Whereas in Spain, inside the hospital, we have the transplant team and a separate team that is taking care about organ donation. It's an organ donation unit that in the past, this organ donation activity was taken care by the transplant teams, but this didn't work because we need the ICU people to be involved to change the culture and the practice inside the ICU to ensure organ donation is a fact. So we end up having a national competent authority that delegates the operational part to many regional authorities, that each regional authority takes care of many hospitals. So our main network is this hospital network of people working and taking care of organ donation. And in the end, we build this kind of pyramid where we have a national authority taking care of the registries, the waiting listing, the allocation, training, certifying, setting the policies, delegating to the regions on the operational part, on validating that hospitals are doing it adequately, on supporting the hospitals, developing more hospitals, joining the network. And then our base of the pyramid, the most important component, are the hospitals. We need the resources to be inside the hospitals because the donors are inside the hospital. And these teams are the ones taking care of donor detection, diagnosing the brain death, family approach, organ donor management, donor evaluation, all the process except for the allocation that is taken care by the national authority centralizing the waiting list. This way, the national authority guarantees there is transparency, that there is a criteria, there is equity in access to transplant, and that this is done in the right way. As I said before, these organ donation teams, they are ICU specialist. This can be an ICU doctor or an ICU nurse, but having an ICU background means that we understand how to manage these brain death patients. And sometimes we have people working full-time or working part-time in the hospitals for this. This depends on the hospital size and the potentiality. We all started being part-time coordinators and ended up being full-time when we reached that point of maturity inside our hospitals. And we answer, as we say again, we take care of the whole disease donation process, identifying every patient admitted, following up every case, making sure we consider brain death, making sure we offer the opportunity of donation in all the cases, approaching the families, taking care of the tissue donors, cornea, bone, skin, but also we oversee in the living donation the donor side. No, the nephrologist, the surgeon is taking care of the recipient, is taking care of ensuring the donor can be a donor, but then the organ donation unit usually what's taking care of having clearance that this living donor is doing it altruistically and there is no conflict in this donation. So we are the ones caring for the living donor in this living donation process. And this network in Spain grew through the years, so it started being less than 20 teams inside the hospital. We have more than 185 teams, and these teams may have 2, 3, 4, 5 people working on them. But these people every day wake up thinking, how can I have more donors? Because our problem is the patient dying in the waiting list. So every day we need to push these boundaries to detect more cases and guarantee we have more organ donors so we can have more transplants. And we care again we can have this care for this living donation in ensuring the clearance for the living donors, but also we care for the brain death donors, for the DCD donors, for the tissue donors. We care for the research and education of all the teams inside the hospital, so everyone is aware about this kind of problem. And we are involved as an organ donation unit in all the process of organ donation until the retrieval. So we are not taking care of the transplantation because transplant is a different team, but all the process from donor detection until the retrieval is where the coordinator is involved and is taking care of the case, following up, and ensuring that everyone is applying the best practice. So thank you again. Thank you for this opportunity and space to share these practices. I leave here my email. So if anyone has any doubt, any comment, needs any help, I'm here to support. As Dr. Shuri mentioned, I'm heading the international cooperation programs in the DTI Foundation. In DTI, we're a non-profit organization based in Barcelona, Spain, that our mission is to help countries develop these kind of things, develop organ donation, organ transplantation, and I'm here to help others. So if anyone needs any help on this, please feel free to contact me, and I will do my best to be there with you.
Thank you, Dr. Brian. That was quite thought-provoking presentation. I know just having looked at the map that you shared, I have seen Africa is barely white. There's no actually activity in terms of diseased donor transplants that are happening. I think there was just a little blue dot somewhere in North Africa. Not sure whether that's around Egypt or Morocco. But yes, I think the things that you discussed that we need to put in place, I'm not too sure if we have a legal framework, especially when it comes to diseased donor transplants yet. Maybe that's a challenge to us to work on that. I think there are also other things that you mentioned, having a transplant coordinator, very important. It's also quite important to think about having other specialists on board, like an interventional radiologist. I know there are quite few in Kenya, so that is something that we should also consider. But again, looking at when you are discussing the aspect of the DCD versus the DBD, And you see the donors that we are having after circulatory death sounds a bit tricky. I think the ones after brain death look quite straightforward because you're able to prepare the family. Sometimes you're able to get at least the family to agree and even to give consent. But the ones that you discuss in DCD, I think you said 2 and 4, which occur in an uncontrolled, if you call them uncontrolled, you find they happen quite sudden, and it's very difficult to control and do that. So that is quite a bit of a challenge there. And again, just to loop into a question that Dr. Lloyd had asked, I also had a similar question. You had mentioned for the donors, for the deceased donors with circulatory death, there was a bit of warm ischemia setting in. So in terms of having graft outcomes, it looks like the ones with brain death are more preferred as opposed to the ones with circulatory death, because probably they might have better outcomes in terms of graft, actually uptake, and also, if I can use a rudimentary term of life expectancy. So I don't know whether you propose one or the other for that. Maybe you can start with that, but thank you.
Thank you for this is a great question. It's the right question, no? First, the first thing you mentioned about the need for a law in Africa and how the map looks like now. The problem right now in Africa is that most of the countries don't have a legal framework to start it, so they are waiting for that. But it's tricky, no? If there is no need to legislate something, then the legislators will not do it, and how to start, no? My first advice that I always give to people from countries that are starting is that you don't have to invent the wheel. I mean, there are lots of laws of countries that we have been doing this for many different years, and we have learned from mistakes. So my best advice is try to use as a starting point the laws from countries that have done this before and have done these mistakes, so you can already have a strong and simple law and don't need to draft it from zero. So that's very we have done this similar in countries from Caribbean countries that they have followed for other countries inside the region and their legislation, and then it has been easier for them to draft the laws. But about the specific question about donors after brain death or after circulatory death, the thing is, like, in the donation after brain death are the ones having the best straightforward outcome, because, as you say, it's a simple process, and since the kidney or the liver is inside the patient, is already perfused in a normal way. Okay, so if we are able to stabilize the patient and stabilize the donor, then the perfusion is normal. So this kidney, when it's transplanted, is quite similar to a living donor. Now we're talking about a survival, 5-year survival of 95% donation versus 92% in donation after brain death. So it's quite similar. Now, in donation after circulatory death, we know that we will have a period of warm ischemia time, either in control or uncontrolled. No? In the controlled DCD, this warm ischemia time may be shorter, and in the uncontrolled, it may be longer. So if we consider the uncontrolled DCD, the uncontrolled, the one that arrives in the street and comes to the hospital, we're talking about 120 and to 150 minutes of ischemia. In these cases, we will have a higher delayed graft function, so we need more dialysis in the beginning. But when we compare the 10-year survival and the 10-year graft function, they will have similar results to the DBD. So it is a good outcome in the long run. The creatinine is slightly higher in the uncontrolled DCD, but still the graft function in 10 years is good. But it's a system that's quite complex to initiate. Logistically, it's more costly and less effective, because maybe 30% of the cases that we have end up being donors, not because of family consent, but because of the high rate of discards. Now, when we see the control DCD, the control, this one that we withdraw the treatment, is quite similar to the brain death because the ischemia time is shorter, it's in a control environment. So usually the graft function is similar and there's no delay graft function, but we mentioned that we have different ways of preservation. We have this normothermic regional perfusion with an ECMO machine that we are perfusing the organ inside the body. We have the rapid retrieval, and we have the perfusion with the double lumen, triple balloon, triple lumen with preservation solution. So if we are going for the normothermic regional perfusion, the ECMO, the outcomes are equal to a donation after brain death. It's the same. There's no difference. Even in the hearts, there's no difference. Now, if we are going for a rapid retrieval, that we open the abdomen and retrieve the kidneys, then in this case, the outcomes are slightly better in the brain death than in this TCD, but still they are very, very good. So don't be afraid of the donation after circulatory death in a controlled DCD because the results are very good. And if you can use the ECMO, is even better.
Oh, thank you for that. I think if we put systems in place and protocols and we're able to act very fast, anything is possible, especially in the controlled environment. So thank you for that response. I've seen Dr. Lloyd has quite a number of questions in the chat box, so I'll just allow him to unmute and ask. Dr. Lloyd, you can go ahead.
Yes, just a few questions. Brian, how can DTI assist the program within Africa? How do you work? Just for everybody's knowledge, for people who don't know you. I know you're doing a lot of work already, but just in brief.
Oh, thanks for that question. So in DTI, we have different ways of helping the countries. One way is by training. So we help countries doing training activities either for hospital teams in organ donation, either for transplant teams in transplant, teams coming to countries to be trained in different programs, then going back, or we taking the experts to that place and training them, or either we can do it through supporting the countries in developing what they need. No? For example, we have helped some countries in drafting the regulations, in drafting the national protocols, in creating the organ donation units, in helping them in the first cases, or in the transplant, in case of the transplant, in assessing the transplant teams and seeing how they can start a transplant team, training the transplant surgeons, going back, sending our surgeons there. So there are many different ways in many different levels, either in national authorities, in the legislation, supporting ministries of health, or supporting the hospitals directly. So basically it is depending on what the hospital or the country needs, we can adapt that support to make sure that it's feasible. Our main what's for us is the most important is that we don't want to support any hospital or any country in a way that is not self-sufficient. So our final goal is whenever we're going to do a program with a country, with a region, whatever, we want to make sure that this program final outcome is self-sufficient. So I don't want to send a surgeon to Kenya to do the surgery. I want to send a surgeon to Kenya to teach the surgeons to do the surgery, or bring the surgeons to my or the ICU to my hospital, so they can learn and then go back and do it in their country. So that's the way that we do.
Sounds good. Thank you so much. And if you say, what are the three first steps you take for a country to move towards cadaveric transplant? Three first steps, baby steps.
Have a very simple law. Don't make it too complex. Have a very simple law. The most important for this law is not to be an obstacle for you. Sometimes more important than to be a facilitator, because in the long run, it may become a barrier. Second is to have a national authority responsible for developing this in the country. So we need to have someone from a ministry or somewhere that is in charge of pushing this activity in the country. And third, and most important for me, is to have hospitals that are the trauma hospitals, the acute hospitals, having teams inside the hospitals dedicated for organ donation. So we need to have a legislation, keep it simple, national authority to oversee this and regulate it and see how we distribute the organs, and the hospital level, at least in the main hospitals, having organ donation teams, one person, one doctor responsible for organ donation. Think big, think small, start big and move fast. So I don't want to have one in every hospital, just the main hospitals, and then we escalate.
Thank you so much, Ren. Thank you very clear. Outstanding thought.
And this is very feasible. And let me tell you, this in Africa can be very feasible because we have seen this implemented in many countries, and it's done. I mean, I've just been in the Philippines, and it's something that they were able to do it, and they don't have much resources. But then the problem is that patients on dialysis are growing, and if they don't find a way of transplanting them, then this is a huge mess for them.
I think Dr. Lloyd had another question.
You have these green corridors in Spain, the green corridors in Spain. Organ transportation, for example, for the heart, does the entire the lineup stop to let the organ go through the city if you need to, like, taking a harvested organ into transplantation?
Well, in Spain, the thing is, let's say that we have a donor in one hospital. This donor is communicated to the regional authority in charge of the activity. They allocate the organ. They say, okay, the kidney from my donor goes to Dr. Shuri's hospital, the liver goes to Dr. Lloyd's, and the heart stays in my center. So the teams from your hospitals come to my hospital, retrieve the organs, and they go back with the ambulance to your hospitals and transplant them there. Sometimes they need to fly, and if you are in a different city, they fly to my city, they retrieve and go back. But if you are starting, it's better to keep it as local as possible so you lower the cost when we're starting, no? And the ischemia time and everything.
Thank you so much.
Thank you, Dr. Brian. I think there's another question from the Q&A chat box. I think you had probably answered this, but maybe you can just go through it again. A participant by the name Sharifu is asking what are the criteria for the diseased kidney transplant? I think you had covered it, but you can just go through it.
Well, for the diseased kidney transplant, the idea is that this is a patient that is initially evaluated for a living donor. This patient doesn't have a suitable living donor, so they have no other option, and they are included in the waiting list. So they are assessed by the transplant team for transplantation. The information is shared with the national agency. They include the patient on the waiting list if they meet the criteria discussed by the national committee, and then this is ranked. This is ranked by this criteria to say who goes first, second, and third. And whenever a kidney comes for this per patient, they get this kidney.
Thank you for that. I think there's also one question from...
I hope that answers the question, if I understood it well.
Yes, I hope so, Sharifu. In case, I think, yes, I'm seeing is just typed again, asking how do you predict graft survival? Is there any protocols?
Well, each organ is different, no? But specifically talking about kidneys, that's not easy. There's some scores, but to be honest, they don't work to predict graft survival. In our experience, they are not useful because they overpredict the graft failure. For example, they use creatinine as a marker, and we know that creatinine is not a good marker. The main way of assessing the graft failure is by the clinical judgment of the donor team. So if you know that the kidney is working well in the donor, if you know that the urinary output is okay, is stable, then you can safely transplant this kidney to a recipient. And also the final assessment is when you open and you see the kidney and you perfuse the kidney and you see how it's perfused with the solution, this final direct assessment by the surgeon, that's also one of the most important parts. Sometimes the donors may have acute kidney failure, may have some necrosis, but if the donor stabilizes after that, the urinary output is okay, and the kidney failure is not the creatinine is not that high, usually this acute kidney injury recovers after the transplant, and they work well. So just, I would say, don't be afraid of the acute kidney injury if the kidneys start working in the donor. If a kidney is working inside the donor, it will work inside the recipient. And very important, the transplant surgeon evaluation, when they directly see the kidney, how it's perfused, and how it's perfused after the preservation solution is flushed.
I believe that answers the question. Thank you for that. There's one last question that was asked by Dr. Lloyd, whether a graft biopsy is part of the protocol. I think in the cases where you have cardiac death before implantation, maybe this is the uncontrolled scenario. So in case you do have graft biopsy as part of the protocol.
Usually, these uncontrolled DCD donors, the most frequent is that we try to perfuse them in a ex vivo perfusion machine. So we put these kidneys in an ex vivo hypothermic and we perfuse them for 4 to 6 hours and we see how is the resistance and the flow. Sometimes, depending on the kidney, if everything is going perfect, it may not be necessary, and if not, we go for a kidney biopsy. And if we cannot perfuse the kidney, maybe we go for a biopsy before transplanting the kidney. Most of the biopsies are in the DCD donors, no? In the uncontrolled, and if there is a expanded criteria donor, let's say that if it's a controlled DCD donor that is 70, 80 years old, we may need a biopsy. But if it's it's like a brain death. In brain death, we usually don't do biopsy, and if it's a young DCD donor, we don't use biopsy. But think that we may be talking about using kidneys from 90 years old patients. So we're kind of pushing the limits. In this case, of course, we need the biopsy. But if you have a 30, 40 years old donor, that's normal. No need.
Thank you for that. I'm sure Dr. Lloyd's question is answered. Unless there's a follow-up question, Dr. Lloyd?
Yeah, thank you. Thank you.
Okay, thank you. There is no other question from the chat box, so I'll just probably invite one of our panelists. I'm seeing we have a very rich repertoire of consultants in the panelists, so I'm sure they might have a question or two. Maybe just to start with Dr. Twahir. In case you have a question or a comment, please go ahead.
Thank you very much, Yuri, for chairing this session. And I want to thank Brian for an excellent presentation, as usual. I've had an opportunity to work and be trained by Brian with the DTI team. And so I just want to make a comment. One of the challenges we are going to have in Africa, in our region specifically, is defining death. And most of you will be familiar with the situation where a patient is in the ICU and everybody knows that the patient is brain dead, but the patient still is on ventilatory support. But nobody wants to disconnect the patient from the ventilator, and they want the patient to have a systole. So clearly this will not work in in a DBD situation where you want to get a brain dead donor to retrieve their organs, because one of the advantages of DBD is there's still circulation. So if you wait until asystole, then you lose this benefit. So we need to educate our teams, or our practitioners, our clinicians, that when a patient is declared dead, you can disconnect them from the ventilator, and this will facilitate our program. The other challenge which we are going to have is our culture. We'll need to educate our people to accept the issue of deceased donation, because even with living donation, it took some time, but many people have now accepted the concept of living donation, and we are doing successful living donor transplants in most of the African countries. But with deceased donation, many of our cultures will need to be educated to accept the concept of deceased donation. So those are my comments, and I just want to congratulate Brian for an excellent presentation once again. Thank you.
Thank you, Dr. Tahir. As always. And I like how you order your comment. In first, we need to educate the people inside the hospital. That don't think that we cannot start until the society is ready, because society will never be ready. The society will never be willing to talk about death and giving their organs while they are alive. But what is the main barrier that we'll be facing is inside the hospital. Our doctors in the hospitals understanding that this patient whose heart is beating, now he's dead. And if we don't get this doctor inside the ICU understand that, he will never be able to explain this to the family and the family to accept it. So this is the first barrier that we need to push, in educating our doctors inside the hospital, inside the ICU, the doctor, the nurse, everyone caring for this patient to understand that this patient whose heart is beating, now he's dead. And that's why we will stop, and that's a challenge. In our case, for example, the death certificate, the time of death is when we certify the brain death. And that's very useful because you certify the death on the patient already. You have a death certificate, so it's more clear for the teams.
Wow, thank you for that, Dr. Brian. Indeed, challenges are there, but we can surmount them. We might, of course, need to have a family conference once in a while to discuss certain difficult situations. But it was quite an enlightening presentation and discussion with a lot of learning points. And on behalf of Africa Healthcare Network and our panelists, I just want to convey my thanks for coming through and doing this presentation. And we're looking forward to seeing you again in future as we continue with the transplantation series in our webinars. So thank you once again, and till next time, wishing you all the best. Thank you.
Thank you. Thank you again for the invitation, Lloyd.